Good afternoon, everyone. I'm Dr. Vamsi Krishna, consultant neonatal pediatrician at KIMS Cuddles, Kondapur. Today, we'll discuss an important topic: neonatal thrombocytopenia. So many babies we are managing in our NSS, especially the extreme preterm babies and small babies, where we find the platelet count to be low. So we'll be worried whether this platelet count is a normal variant or it could be any other related underlying diseases. So we should have a clear-cut approach how to deal with the neonatal thrombocytopenia. Today, we'll briefly discuss how we can approach the neonatal thrombocytopenia and discuss some case scenarios. So how can we deal with these cases? So to begin with the platelets, we know that they are highly organized nuclear cellular fragments that are involved in the hemostasis. They are first described by an Italian physician, Giulio Bazzaro, as a third morphological element of the blood. They are produced from the megakaryocytes and they require thrombopoietin for their production. The normal half-life of the platelets is around 5 to 7 days. The normal platelet count in the newborn is around 1.5 to 4.5 lakhs. So first, the thrombopoiesis begin in the fetus around 5 weeks after the conception. And by the end of the first trimester, there will be around 150 into 10 to the power of 9 per liter of the platelets will be there. And the values reaches the adult range, that is around 3.5 to 4 lakhs by around 22 weeks of the gestation. So we can know that the thrombopoietin is required for the production of the platelets. The thrombopoietin will be produced from the kidney and the liver, and the thrombopoietin will stimulate the myeloid stem cells, and then megakaryocytes will be produced, and the megakaryoblast, from the megakaryoblast we will get the megakaryocytes, and ultimately we'll get the platelets. So the most important steps is first there's the production of thrombopoietin factors from the kidneys and the liver. There will be a proliferation of the megakaryocyte progenitors that can be colony forming or burst forming units, and there will be happens a different kind of the things where the cell doesn't divide, and there will be a different kind of cytoplasmic maturation, and there's a beautiful process called endomitosis where the nucleus doesn't get divided. There will be increase in the DNA content in the nucleus, and finally the platelets are produced and they're released into the circulation. So the incubation of the precursor cells in the bone marrow is required, and further the thrombopoietin is needed, and which along with other cytokines will stimulate the megakaryocyte proliferation and survival. The thrombopoietin is produced in the liver and the gene that is responsible for the production of thrombopoietin is MPL gene that is located in the chromosome 1p34. The thrombopoietin produced in the liver and the kidney at a constant rate. This thrombopoietin then moves to the bone marrow where it binds to the thrombopoietin receptors in the bone marrow cells, and it activates the Janus kinase and STAT pathways that lead to the production of the megakaryocytes. In this figure, we can see that the pluripotent stem cells, and from where the myeloid progenitor cells will form. The myeloid progenitor cells will form the burst-forming unit megakaryocyte, which forms a much differentiated colony-forming megakaryocyte. Then we get the megakaryocytes, and their endomitosis happens, and that ultimately results in the formation of a small platelets. So there's a quite difference between the megakaryopoiesis in the newborn and adults. The megakaryocytes in the neonates are small size and the low ploidy, whereas in adults are big size and the higher ploidy. Thrombopoietin may stimulate for the production of the platelets, but in neonates, it inhibits the polyploidizations. So there will be less amount of ploidy. However, the sensitivity for the thrombopoietin is much higher compared to the adult. The reserve platelet production is less. So overall these things, we have a small platelets with a lower ploidy because of thrombopoietin action itself, the polyploidizations in the neonates. However, the thrombopoietin action is sensitivity. So will that lead to the production of very large number of high mature megakaryocytes which rapidly proliferate. So they produce more amount of precursors, and this will lead to the occupying the space of the rapidly growing bone marrow in order to maintain the normal platelet count. So the platelet size is small, the ploid is small, but the proliferation rate is much higher. So in this way, there will lot amount of the platelets will be produced. So this amount of platelet will cover the bone marrow, and this way the platelet count is maintained. So the platelet count is not a fixed value at all the gestation list. So the Widmer and the collaboration published a large study on the neonatal platelet count, which included around the 47,000 infants who have been delivered around 22 to 42 weeks. So in this graph, this is a most common graph that has been shown in any kind of a thrombocyte presentations. So this is present in the every also. So we can see that this is a fifth centile, the blue curve, and this is a green curve is a 90th centile, and the mean is around the red one. So we can see that around 22 weeks, the fifth centile can even drop below the 1 lakh. Maybe sometimes it can be seen around the even 95 to 80,000 also can be said. and there can be this amount of less than central can be around 1 lakh, may not be even reach 1.5, and usually around 35 weeks of the gestation where you can maybe hardly touch around 1.5, and by the term gestation they usually present above the 1 lakh. Still some babies can have, may not reach the 1.5, so they can have the 1 lakh. So the mean usually maintained around the 2 lakhs. The platelet number, the platelet function also will be differ in the newborns and the adults. So in vitro, we can see that the platelets in the neonate are hyperreactive from the adhesions and the activation. The hyperreactivity is much more pronounced in the preterm neonate. So we worry why, how come these neonate platelets, even they are producing a good number, are very hyperreactive. So for the platelet to get responsive, the it should be responsive to the epinephrine, collagen, thromboxane, and thrombin. But the response to these agonistic are much less. So the epinephrine responsive is less because the epinephrine should act based upon the alpha receptors on the platelet, but they have a few alpha receptors. It is very hyper-responsive to collagen because the platelet need to produce more amount of the calcium mobility will be there, but these platelets in the unit is less responsive to collagen because they don't have an adequate amount of calcium mobilization from the sarcoplasmic reticulum. They're also less responsive to thromboxane because the downstream signaling from the receptors of the neonatal platelets for their action is less in the case of a neonates to the thromboxane. And also for thrombin, the response is less because of there is reduced expression of the important protease activated receptor 1 and 4. So in this way, we can see that the physiologically the platelets are less responsive to various kind of the agonistic. Then we may worry how there's so much of hyper responsive to all the important agonistic, how this the newborn platelets are able to maintain the hemostasis. So to counteract this ones, they have a very high hematocrit, they have a very high mean corpuscular volume, there is a high concentration of 1 milliband factor. So these factors will counteract this hyperreactivity and enhance the function. All these above factors are less developed in the premature infants. There is less amount of hematocrit, less amount of mean corpuscular volume, less concentration of 1 milli factor, but still they can be maintain their normal hemostasis when the conditions are favorable until unless they become sick. So any kind of sickness like respiratory distress syndrome, like sepsis and shock, which affect this hemodynamic balance, then they can develop more amount of hemodynamic, coagulation abnormalities, and they can have the abnormality with the platelet count. But however, if your babies are maintained normally, these functions will usually get normalized even the preterm babies by 10 to 14 days. But the problem is majority of the preterm babies have these kind of the side effects related to the platelets, and bleeding happens in the first 10 days. So that's why we need to meticulously monitor these babies for the sepsis, shock, respiratory distress, and the counts also. We take the cutoffs are much lower in these babies much higher compared to the babies who are normal and have the low platelet count. If you cross this 10 to 14 days, then all the values will be similar to the term babies, and the babies, the hemostasis will be adequate. Then, based upon the basic of the platelet count and the difference between neonatal and adults, now we move on to the proper topic of neonatal thrombocytopenia. So traditionally, we label the thrombocytopenia as a platelet count less than 1.5 lakhs in the neonate of any gestation age. But we have seen that in the previous slides that the fifth centile can vary in the different gestation ages. So we have seen that the Vadimer et al. Has done the study 47,000 preterm infants and the term infants, and they found that even the term and the preterm infants, the platelet, the fifth centile can be around 1 lakh to 1.5 lakhs also. But traditional will take any platelet count less than 1.5 lakh as a thrombocytopenia. So when you classify the thrombocytopenia, we'll classify based upon two things. One based upon the severity, we'll classify as a mild, moderate, and severe. The mild is 1 to 1.5 lakh, the moderate is 50 to 1 lakh, and the severe is less than 50,000. So this is based upon the severity. And then will based upon the time of onset. So the early onset thrombocytopenia is the thrombocytopenia happening in the first 72 hours of life, and the late onset thrombocytopenia happening beyond 72 hours of life. So in the early onset thrombocytopenia, the baby, the thrombocytopenia onset in the first 72 hours of life, and based upon the clinical condition of the baby, the causes are different. In a well baby, if they are mild to moderate thrombocytopenia, if the babies are an IUGR, birth asphyxia, Doppler abnormalities, and you have a placental insufficiencies, then it can be more related to the mild to moderate thrombocytopenia. So in these cases, because of placental insufficiencies, there will be having hypo response of your bone marrow that can be related to mild thrombocytopenia. But in these cases, it will not go into the severe thrombocytopenia, and they usually get improved by around 5 to 7 days of life. Sometimes immune-mediated thrombocytopenia can also be mild to moderate, but majority of the time immune-mediated thrombocytopenia is severe and the babies usually appear well. So the immune-mediated can be autoimmune in the case of SLN-ITP mothers, in the case of alloimmune, in the case of NAID, sometimes it can be well, severe thrombocytopenia can be drug-related. And there are a few conditions where the aneuploidy or innate disorders where the bone marrow itself is not able to produce adequate amount of thrombocytopenia or megakaryocytes. However, if early onset, if the baby is sick, then we should rule out the sepsis, congenital viral and the parasitic infection. There could be DIC that can be related to severe sepsis or birth asphyxia. There can be metabolic disorders like propanol methylmalonacetamias, and there can be inherited disorders like a TAR and the CMT, which we'll discuss in the further, or can be thrombosis where the baby is having in any central lines. The late onset thrombocyte happening beyond 72 hours, usually they're related to most common causes of necrotizing enterocolitis or any late onset sepsis, either bacterial or fungal, or that could be congenital infections like congenital viral, CMV, toxoplasma, rubella, herpes HIV, and there can be autoimmune disorders can present in the late onset thrombocytopenia. There can be Kasabak-Merit syndrome where the conjunctive coagulopathy will be there, and their metabolic disorders can present in the early and late. There can be hypercholesterolemia, methylmalcalcemias, or there can be inherited bone marrow disorders where the production of the megakaryocytes and the platelets is affected. So one should, when before going into the evaluation, we should have a basic history. So one should ask for the maternal history, whether the maternal history herself has a thrombocytopenia and whether it's symptomatic or asymptomatic. And we should note whether the onset is in the pregnancy or present beyond, because certain pregnancies can have a thrombocytopenia. They can also gestation thrombocytopenia. There can be any SLE or an idiopathic thrombocytopenias, Evans symptoms in the mothers that can be identified for the first time in the pregnancies. So we should know when the onset of thrombocytopenia, what is the lowest count, and what are the interventions. Any that mother has received any platelet transfusions or any other drug that promotes the thrombopoietin like action drugs has been received in the mother. We should ask whether the mother had any similar episodes in the past where there is stuff, any splenectomy or transfusion that has happened in the past, whether the mother has any stuff fever with or without Russian anteal period that can suggest you any congenital torch infection in the mother, whether the mother has been exposed to any drugs like clonidine, penicillin, digoxin, or antiepileptic drugs, or she might have received the chemotherapy drugs during the pregnancies that can be transferred to the babies intrauterine and that can be lead to the thrombocytopenia in the babies. Sometimes there can be any stuff of bradyarrhythmia noted during any examination antenatally by the mother and the baby that can be led to the SLE, or where there is stuff any pH and preeclampsia, as we've seen the early onset mild to moderate thrombocytopenia, well baby can be related to the uteroplacental insufficiency itself. The family history, we should ask any family history of bleeding disorders present, like in the case of any family congenital disorders affecting either platelet function or the platelet production. There can be any other family history or any previous sibling history of neonatal thrombocytopenia. Again, there could be inherited disorders can be there. Then we should ask for any labor and the delivery related issues, any abnormal fetal motoring or atrial station that can be perinatal asphyxia that can lead to bone marrow suppression or DAC. The prolonged labor itself can lead to the any bleeding or asphyxia that can lead to the DAC. In small SGN newborn babies, because secondary to placental insufficiency itself can cause to the mild to moderate early onset thrombocytopenia. We need to examine the infant thoroughly in order to find whether the evidence of bleeding, or if there is a bleeding, how extensive the bleeding is there. We should assess for the cephalohematoma using from the umbilical cord or punctured sites. Is there any hematemesis? Sometimes the hematemesis can be related to the swallowing blood, but if it's not in swallowed blood after doing this up test, then we need to work up for any bleeding disorders in the babies. We should see for any melena and any blood thinning secretions. We should assess overall the clinical status whether the baby is sick, requiring inotropes, requiring the respiratory support or not, or the baby is completely stable. There certain can be disorders of the liver itself that can lead to the thrombocytopenia, and we need to find any dysmorphic features that relate to the trisomies or just like an absent radius, like a TAR, or any limb hypertrophy where you can see the Kasabak-Merit syndrome like things. And we should see for any hemangiomas either in the skin or if the baby is an extensive hemangioma, we can do the ultrasonography abdomen to look for any intra-abdominal hemangiomas that can lead to the conjunctive coagulopathy. And always look for a presence of a central catheters, because one of the most common cause of thrombocytopenia in well babies with a central catheter is related to the catheter-related thrombosis. So the basic investigation will see the complete blood count where we can see anemia that could be related to the bleeding, or it can be affected to the bone marrow along with the thrombocytopenia production, along with affecting the megakaryocyte production defects. There can be leukocytosis and leukopenia based upon the clinical condition, and we need to see the platelet count. And also we need to see the peripheral smear based upon the size of the platelets. Certain congenital thrombocytopenias can be identified. So if you have very small platelets, then it could be viscoid syndrome, which is next linked to macrothrombocytopenia, where the babies have a rash, thrombocytopenia, usually seen in the male babies having a diarrhea. If you have a normal size platelet, then we can see the congenital megakaryocytic thrombocytopenia, where there can be other associated anomalies that we can see in the subsequent sites, or it can be TAR. TAR is a thrombocytopenia with absent radius, or it can be associated with thrombocytopenia with other trisomies like 13, 18, and 20. The large platelets usually associated with MH9 as a thrombocytopenia that can be Meheglin anomaly, Sebastian syndrome, Fechner syndromes, and Epstein syndromes, or there can be functional problems, the Bernard-Sollier disorders, where the platelets are large and then thrombocytopenia will be there, but the more problem is often not because of thrombocytopenia, because of the hemostasis securing. Or there can be X-linked macrothrombocytopenia, there is a Paris-Strauss syndromes and gray platelet syndromes. So in this way, based upon the peripheral sphere, based upon the size of the platelets and thrombocytopenia, we can have an idea of the congenital thrombocytopenia. Then one of the recent thing is one is the immature platelet fraction. The immature platelet fraction similar to the reticulocyte count, it measures the platelets that has been released within less than 24 hours. So if the immature platelet fraction is high, then it indicates that the platelets are being destroyed. That could be immune or non-immune mediated platelet destruction. If your immature platelet, like your reticulocyte count is low, it means that there is decreased production. The decreased production can be a bone marrow suppression secondary to the sepsis or any other metabolic or any other drug-related issues, or it could be congenital thrombocytopenia disorders. So there are certain mature platelet fractions. Differences are there for the different age groups. For umbilical cord, 0.7 to 3.8 is the immature platelet fraction reference. The lower limit for the 95th centile is 0.7 to 0.9, and the upper limit is 3 to 3.8. But the reference values are still being evaluated for using the larger group of the babies. So usually the immature platelet fraction help to evaluate between thrombocytopenia, and they can affect the platelet count. There are certain studies found that the absolute immature platelet fractions low in a baby usually suggest a poor prognosis in case of the NEC, and it can help in both the prognostication and also help in the understanding the causes of the thrombocytopenia, either it is because of the destruction or because of the production deficits. Then we have a reticulated platelets. These are newly produced platelets with increased RNA content. So in the case of a reduced platelet production, similar to the immature platelet fraction, the reticulated platelet count will be below the percentage less than 2%. If there is a more destruction, there more amount of the platelet being released in the form of more amount of reticulocyte count in the case of the anemia, hemolytic anemia, there will be more than 10% of the reticular platelet count will be there. And this usually be diagnosed by the flow cytometry. They have a different kind of molecule. Based upon flow cytometry, they will identify, and based upon the population of the platelet, if it is less than 2%, it is decrease in the platelet production. If it is more than 10%, it is accelerated destruction. Then we can see the function of the platelet by the PFA. So here they measure the platelet adhesion and aggression in a whole blood at a high shear when the platelet is exposed to either collagen epinephrine or a collagen ADP. And based upon this closure of the tube, they measure the closure times. So if there is a prolonged closure time, it indicates that the platelet function is not good. If the closure time is normal, that indicates that the platelet function is good. So this is a PFA 100 analyzer will be there. Then we have a platelet aggregometry. In these aggregometries, there is various agonistic will be there. They're added to the platelet plasma, and they see the clumping of the platelets over the time is measured. Simultaneously, other instruments measure the release of the granular content such as ATP from the platelet after they get activated. So the ability of the platelet to aggregate and their metabolic activity can be assessed simultaneously by using the platelet aggregometry. Then we can see the flow cytometry. We can see that Glanzmann thrombocythemia, where you can the glycoprotein 2b38 defects will be there in the Bernard-Sollier, the glycoprotein 1b and 9 receptors will be affected. In the case of a collagen, glycoprotein 6 and glycoprotein 1a, 2a, where the collagen receptors will be affected. So based upon the flow cytometry, by identifying the different receptors, we can know whether it's Glanzmann or Bernard-Sollier and whether it's a collagen receptors. So in this way, we can know what is the thrombocytopenia, cause of thrombocytopenia, how do you handle it. So now we'll discuss few important case scenarios for diagnosis in the early onset thrombocytopenia. So early onset thrombocytopenia, we know that is less than 72 hours is early onset thrombocytopenia. So we'll discuss in the case scenarios. So we have a late preterm baby around 35 weeks who is a male baby born with 1.34 VLBW baby. The baby got delivered vaginally with an Apgar score of 9 weeks at 1 minute of life, and baby is admitted in view of VLBW preterm care. Mother doesn't have any history of pH, preeclampsia. There is no history of any fever, leaking pericarditis, history of any maternal infections, and the CBC was normal for the mother. The baby is noticed to have a purpura with prolonged bleeding from the puncture sites around 6 hours of life. On examination, the baby was vitally stable. There is no dysmorphic feature. There is no hepatosplenomegaly. However, the baby's CBC count is around 70,000. So this is well baby, VLBW baby with normal maternal history, vitally stable. However, the baby doesn't have any other anomaly. Baby have a thrombocytopenia, which is around 70,000, which usually has a moderate thrombocytopenia. So what do we consider the possibilities of this case? So this is an early onset thrombocytopenia because it is 72 hours. This is a well infant baby when you see the vitals are stable, and it is around moderate to severe thrombocytopenia. And there is no history of any placental insufficiency. Baby has cried. The baby is not a significant IVR. There's some amount of IVR is there, but there isn't a very impact restriction. So severe well baby, early onset thrombocytopenia, I would consider these babies should be having any immune mediated thrombocytopenia that can be auto or alloimmune thrombocytopenia. I'm not considering autoimmune thrombocytopenia because as we had that CBC is normal. So this baby might be an alloimmune thrombocytopenia. So we'll see how it is alloimmune thrombocytopenia there. So well infant severe thrombocytopenia and is an alloimmune thrombocytopenia. So we done investigations, so normal coagulation profile, the sepsis screen was normal, X-ray of the lips normal, USG skull was normal. So which ruled out other causes of the routine early thrombocytopenia. So the platelet count were low, 70,000, and then slowly got improved by around 14 days to 18,000, and by 20 days it is around 1.3 lakh per day. So the NATE diagnosis was made in these babies based on the positive indirect platelet immunofluorescence test and spontaneous recurrent thrombocytopenia. So how do you decide the NATE? So NATE, neonatal alloimmune thrombocytopenia. So this is a platelet equivalent of hemolytic disease of the newborn, HDNB, where like it's in RH immunization. This is a platelet equivalent of HDNB. So this is the most common cause of severe early onset thrombocytopenia in a stable baby. The incidence are 0.5 to 1.5 per 1,000 live births. So what happens is that the antibodies are being produced against the human platelet antigen that is present in the fetus but not in the mother. Similar like an RH thing, where RHD antigen that is present in the baby but not in the mother. Here, similarly, the mother doesn't have any antigen, but the baby has an antigen, might be inherited from the father. So these mixing of the blood will be there. The antibodies are being produced against this antigen, and these transplacental antibodies will be going into the baby, and this causing destruction of the platelets. So coming to genetics, the gene that is encoding the surface antigen on the platelet is especially glycoprotein 2B and 3A, which undergo single nucleotide polymorphism. So there is a single nucleotide polymorphisms that lead to the development of antigen that is responsible for the NATE. So the most common is human platelet antigen 1A followed by the 5A, which was major causes in the whites. Sometimes we even see the human platelet antigen 9B, 3 and 3B. In a case of Asian ethnicities, especially Japanese population, even the human platelet antigen 4B is also plays an important role. So the ability of this human platelet antigen 1A negative women to form the anti-human platelet antibodies is controlled by the HLA-DR B30101. So any mother who had HLA-DR B30101 positive compared to the who doesn't have doesn't have this HLA-DR30101, the chances of producing the antibody is 140 times more likely. So we have a mother who doesn't have human platelet antigen 1A. The baby is having HPA1A inherited from the father or any other antigens. So there will be reactivity, the antibodies will produce, and the mother who had this HLA-DR B30101 has more chance of producing more high titers of the antibodies. So in this picture, you can see that, so your mother, the baby is HLA, human platelet antigen 1A, 1B fetal platelets. This might be inherited from the father and that's not from the mother. So the mother is negative. The baby platelets enter the mother's circulation similar to your RKS immunization type mixing happens. So the mother will produce the HPA1B antibody. This transplant will go into the baby and this causes destruction of the platelet and lead to the thrombocytopenia. So mostly the milder cases will not get diagnosed and the severe reaction may cause intrauterine death because they can lead to the intracranial bleeds. The features immediately at birth or shortly may present like in a case of a mild bruise or bleeding with a petechia. Sometimes may be asymptomatic also. In a case of severe, they can present with a bruise or petechia. Sometimes we can see the baby might be found with a severe intracranial hemorrhages. So the intracranial hemorrhage is a parenchymal hemorrhage that we can see, not in the intraventricular hemorrhages. So sometimes the hemorrhage can happen in utero around 14 to 16 weeks of gestation. The incidence is higher with the case of a NATE, nearly more than 20% babies can develop intracranial hemorrhage and may occur. Any baby who had in the previous pregnancies has a high chance of recurrence in the further pregnancy that can even go to around 100% in the next pregnancies. For diagnosis, we get a complete CBC. We see that there is a mild to moderate mild, moderate, or severe thrombocytopenia. Then we'll see for the mothers and the father blood for the HPA human platelet antigen 1, 3, and 5. If you strongly suspect Then sometimes we can extend to the HPA 9 and HPA 15. And in the case of Asian descent, where you have a strong susceptibility, we can even go for the HPA 4 antigen assay. We can even see the antibodies, the HPA 1A antibodies in the neonatal serum, but the antibody status will be low, and sometimes will be false negative reaction, false negative reports can happen. It's always better to have a mother and father blood serum testing for the human platelet antigens. And any baby who suspect with the NATE need to get an ultrasound cranium immediately to diagnose the intraparenchymal bleed. And the management is different in different scenarios. So there are 3 different scenarios can happen in our life. One, we can have a baby who had a moderate severe thrombocytopenia, well baby. We are suspecting NATE, but we are not diagnosed antenatal or in the previous pregnancy. The second thing is we know this mother already had a previous history of a NATE, and we have proven this in this baby also there is a chance for the NATE. So how do you manage in this baby? And third thing is, how do you want to manage in the pregnant woman in order to prevent the intracranial hemorrhage who had a history of previous NATE? So the first thing, suspected NATE. So we don't have any proof there. We are suspecting this to be NATE based upon the well-being of the baby and severe thrombocytopenia with a more normal maternal thrombocytopenia. So we have sent the investigation, but we need to monitor the baby. So we can give the random donor platelets in this baby as a first line of management. So clinical stable babies without any intracranial hemorrhages, we usually doesn't give below 30,000 platelets. If there is any baby who has a sick, like a preterm baby, or a baby who had a respiratory distress, or has being sepsis, we try to maintain beyond 50,000. Suppose if the baby had an intracranial hemorrhage, we maintain beyond 1 lakh. So the first line of agent is random donor platelets. We give transfusion in stable babies if it is less than 30,000 without IC bleed. In the sick babies, we'll give transfusion if less than 50,000. The sick can be respiratory distress syndrome, premature baby, sepsis, shock. And in the case of any ICH blood, whether the baby will be anyway sick, but any ICH blood, we want to maintain the titer beyond 1 lakh. Sometimes babies can fail to respond to the RDP, then we need to give the antigen negative platelets. Suppose, in these babies, we can also give 1 gram per kg of the IVIG for 2 consecutive days in case of an unwell baby, strong suspect of the NATE, and the platelet count is less than 50,000. This immunoglobulin will increase the patient's own platelet and also will protect the transfused platelet by being destroyed from the antibodies. So we tend to give this IVIG baby around the platelet count 30 to 50,000 so that it will prevent the further drop in the platelet count by damaging the own platelet and also protect the transfused platelets. So one thing is less than 30, we give the platelet. 30 to 50,000, we'll start IVIG and also we'll give the platelet to the baby sick. More than 50,000, we don't give the platelet transfusion until unless the baby an IC bleed. In IC bleed, we're trying to maintain the platelet count beyond 1 lakh. The first choice of the platelet is RDP. If the patient is not responding, then we'll give the antigen negative platelets. So suppose we know that this mother had an history of NATE, or antenatally we have diagnosed this to be a NATE by means of genomic studies, then we always get delivered in an institute where we have a genotypically matched platelet, that is human platelet antigen 1B, 1B platelets. This should be available in the blood bank at the time of the delivery, and this is the first choice of the drug. Sometimes if you're still not able to get, then there's no option, we can give the RDP, but it's always preferable in a proven case of NATE to give the human platelet antigen 1B, 1B. The next thing is, we know that mother is already history of a NATE. Then how do you manage this mother antenatally? So the aim is to assess and minimize the risk of the intracranial hemorrhage in this current pregnancy. We need to follow this mother in the high obstetric clinics during all the future pregnancies. The father phenotype to be determined. The recurrence risk is 100% if there is a homozygous dominant. We need to even do the fetal genetic testing and know to see what kind of the platelet antigens are there in the babies. For a maternal, we can give 2 things. One, we can give the 1 to 2 gram per kg per week of IVIG with or without steroid. The steroid we can give the prednisolone or 0.5 to 1 mg per kg per day. We can start at 12 weeks and continue till 26 weeks if there is any previous history of intracranial hemorrhage. If there is no previous history of intracranial hemorrhage, then we can start at 20 weeks and we will give it shortly at 26 weeks. And these babies, in order to prevent the intracranial hemorrhage, we always prefer to give the cesarean section. So you know the mother is antenatally diagnosed case of, we know this pregnancy, the mother had an history of NATE, then we follow up in high-risk center. We give the IVIG and the prednisolone starting at 12 or 20 weeks based upon whether the previous baby has history of ICH. If the previous baby has history of ICH, we'll start at 12 weeks. If the previous baby doesn't have any history of ICH, we'll start at 20 weeks and we'll give to the 26 weeks of gestation. And we deliver the baby by the cesarean section. Immediately after the delivery, we screen for the intracranial hemorrhage. And based upon the platelet count, less than 30 will give the platelet, the 30 to 50,000 will give the IVH and the platelet, more than 50. If there is no ICH, we'll don't do anything. If there is an ICH, we'll want to maintain beyond 1 lakh. The first choice here, in the case of a known case, is always the human platelet antigen 1B, 1B. If the platelet, if you don't know, then we can give the RDP and try. Sometimes we can even get the platelet from the maternal blood after the doing so much of concentration after washing off the antibodies, but the washing and the screening can lead to the destruction of the platelet. So it's like a last resort for you can do. So that is one scene of a NATE. The next thing is, suppose we found a full-term baby is being born to a mother who had a maternal thrombocytopenia. Baby is otherwise okay, had developed petechiae purpura and 12 hours of life. There is no any previous siblings or any family history of thrombocytopenia. We examine the baby is well, vital stable, no evidence of bleeding, no dysmorphic features, but your platelet count is around 1 lakh. What do you consider? So this early thrombocytopenia in a well baby, and it is also had history of thrombocytopenia. So any mother who had history of thrombocytopenia baby should be screened immediately with the cord blood or in the first 1 day of life with the platelet count. If the platelet count is normal, then it is normal. The platelet count is low, then it could be more related to the autoimmune thrombocytopenia. So we have an early onset, well infant, mild to moderate or severe thrombocytopenia, maternal history of thrombocytopenia, then it is immune mediated, then it could be autoimmune thrombocytopenia. That could be maternal SIL related or any idiopathic thrombocytopenia related to any other conditions. So neonatal autoimmune thrombocytopenia is mediated by the maternal platelet autoantibodies. So there are antibodies that are present to the maternal antigens itself in the mother. The principally maternal ITP and SLE conditions where the babies can also get the neonatal autoimmune thrombocytopenia. It is very rare, happens 1 to 2 of 1,000 pregnancy thrombocytopenia, and it nearly around 10% of units. The clinical feature, babies are otherwise healthy. They usually have a thrombocytopenia related problems like petechiae and bruise. So that could be severe if the maternal splenectomy has been done, the maternal platelet count is less than 50,000 at any time during the pregnancy, or if the previous sibling had any adult thrombocytopenia, then the chance of having the severe thrombocytopenia requiring multiple transfusions is high. So what we do is we monitor the platelet count either in the cord blood or the peripheral blood. If the platelet count is normal more than 1.5, we leave it, we don't do any other further investigation. If you have case of a thrombocytopenia, we'll repeat the count after 2 to 3 days. Then the count usually, if it is not severe enough, it is okay, usually resolved by 2 to 3 days or at least by spontaneous by 7 days. However, if you have a very severe thrombocytopenia in a case of less than 30,000, where in a case of a NATE we are given RDPs, here the first choice of life is we give the IV agent. We'll give the RDP platelets if there is any bleeding is there or if the count is less than 30,000. So if it's less than 30,000, we'll start with IV agent the first line, and to back up, we'll use the platelet count in order to prevent the bleeding. If there any platelet count of less than 50,000, we always routinely obtain the cranial ultrasonography in order to look for any bleeds. So neonatal thrombocytopenia, secondary compared to the NATE, usually get resolved in 1 to 2 weeks. But in the case of a neonatal thrombocytopenia, secondary to the maternal ITP, this neonatal autoimmune thrombocytopenia can last weeks to months, sometimes may require second dose of IVIG around 4 to 6 weeks. However, compared to the NATE, the chance for the intracranial bleed is less until unless the baby has very severe thrombocytopenia. So the choice of the delivery is an obstetric indication rather than a gynecological consideration. So the next case scenario is we have a 2 days old female baby is born by the non-consanguineous parents, presented the complication of bleeding manifestations on the skin. So the pregnancy was uneventful. There was no history of any maternal illness, fever, rash, no history of any maternal thrombocytopenia. Baby delivered by vaginally, stable babies, where the baby has certain facial dysmorphic features. The baby had purple rash with the abdomen and the lower limbs. This baby also had an absent radii, the radial deviation of both the limbs with no thumb deformities. We are seeing the TLC count is pretty high, around 49,000, and the platelet count is 20,000. So what do you consider? So we have a dysmorphic baby, no maternal thrombocytopenia, maternal uneventful. Baby had a thrombocytopenia with absent radius and the radial deviation of the bones. So what is the diagnosis in this baby? So this is a case of well baby, early onset of a well baby, and severe thrombocytopenia. Then it could be any genetic disorders or it could be any inherited disorders of thrombocytopenia. So the congenital thrombocytopenia, the conditions where there is a reduced platelet production secondary to the either abnormal hematopoietic stem cells itself, is pluripotent stem cells, or the progenitor cells like pus forming or a colony forming unit megakaryoblast. So they're syndromic, usually rare condition that most often present at the birth itself. They're heterogeneous with variable clinical manifestation based upon different clinical manifestation can happen. Often, but not always, patients have dysmorphic features and are associated abnormalities as a part of the genetic syndromes. The non-syndromes usually history of a chronic thrombocytopenia in the families, and there is a heterogeneous group of the disorders. So the condition that we have discussed could be a THAR. The THAR is a thrombocytopenia with a bilateral absent radius. So the radius is not absent, so there will be radial deviation will be there, and there have a other associated phenotypes. So the inheritance is autosomal recessive. The gene is chromosomal 1q21 RBM8A. The clinical features usually they have absent radius, they have a club foot, and they have a syndactyly, and they have a clinodactyly. The skeletal abnormalities, they have a hip dislocation, femoral or tibial torsions. There is a facial anomalies. They can even have a cardiac defect like a TOF, ASD, VSD. They can have CMPS, and they also can have renal anomalies can be there. So this is a baby with a TAR where you can see that there is an absent radius, there is a radial deviation, there is a clinodactyly. So this is a baby of a TAR. The blood picture usually similar to there is a lack of a thrombopoietin. There is a decrease to absent megakaryocytes in the bone marrow at birth. Then slowly the megakaryocytes will improve, but they can have a low to the normal level. The thrombocytopenia is very severe at birth because there is absent megakaryocytes in the marrow, and slowly as the megakaryocytes improve, there is improved with age. Now, the platelet size is normal. They have very high elevated WBC. This is one of the indicators that baby might have a TAR. They can have 50, 60,000. There is anemia can happen because secondary bleeding. The thrombopoietin levels are raised because there is a lack of response, but not likely to decrease the thrombopoietin. So other disassociated upper limb abnormalities includes thrombocytopenia with the radio-ulnar synostosis. This is called as ATRS, ATRS, thrombocytopenia with radio-ulnar synostosis, where we cannot rotate, where the baby cannot do the pronation of things. And there can be Fanconi's anemia, where the baby had an anemia, bone marrow failure, thrombocytopenia, and there are multiple facial and the kidney-related issues present in Fanconi's anemia. So ATRS is a megakaryocyte thrombocytopenia with radial stenosis, presents with a very severe thrombocytopenia, and there is absent bone marrow megakaryocytes. So that will lead to more amount of severe thrombocytopenia, and there is a radio-ulnar synostosis. This is called a mutation in the FOXA11 gene. There is inability to rotate the arm. These babies require bone marrow transplantation. The other are Edwards syndromes, Down syndrome, Patau syndromes, Turner Noonan syndromes, where in Edwards syndrome, 86% of the babies will have thrombocytopenia, in the case of Down, 6%, and 31% in the case of Turner syndrome. So this way, this aneuploidies also can present thrombocytopenia, where they have other clinical features pointing to the different diagnosis. Next, where 37 weeks gestation after uncompleted pregnancy to gravida 1, para 1 mother with history of a GBS colonization. The intrapartum is unremarkable. The baby CBC was in of GBS colonization, which suggests to of which suggests of normal levels except the thrombocytopenia of 12 presence. The physical baby is currently at the initial period of time stable. There is no dysmorphic, there is no IVH. Gradually, the platelet count show falling with the worsening of the baby conditions. Investigation suggests for central sepsis and DAC were negative. The viral markers were negative. Even the maternal platelet antibody tests were negative. So this is the baby who had a severe thrombocytopenia, and the baby is going into the suggestive feature suspect of sepsis, like in the case of maternal GBS positive. GBS positive is very rare in India. So these might have this mothers who have any history of any leaking PV, choreamnionitis. These babies will be with severe thrombocytopenia. One should always rule out the sepsis or the DAC. Then we need to move on. So if the mother doesn't have any thrombocytopenia, if the baby doesn't have any other anomalies, then we need to evaluate further investigation like a torch infections, viral infections, chromosomal abnormalities, IEMs. If the baby had any lines can be related to thrombosis, or some kind of IDM babies, or babies who have been dehydration can develop with renal thrombosis, or they can be congenital thrombocytopenia where that production is affected. So congenital thrombocytopenia, one of the important things is congenital megakaryocytic thrombocytopenia. So these are autosomal recessive things where your megakaryocytes are absent. The MPL gene for the TPO, thrombopoietin receptor is absent. So normally what is the thrombopoietin the thrombopoietin lactone thrombopoietin receptors by the JAK1, JAK2, there's a MPL stimulation will be there, the megakaryocyte differentiation happen. In the case of the CAMT, congenital immune thrombocytopenia, there will not be any response to the thrombopoietin, so there won't be any production of the megakaryocyte differentiation, so there can lead to this thrombocytopenia. The choice of treatment in this thing is hematopoietic stem cell transplantations. So there are two types. One, there is a severe thrombocytopenia where it's complete loss of function receptors. We can't do anything. Where there may be required bone marrow transplantation. The type 2, where the mild to moderate thrombocytopenia, there will be partial functional receptors where we can supplement the thrombopoietin stimulating drugs like romplastin, where the babies can try to, with the drugs, can maintain the platelet counts. There are associated physical around 50% of the babies. These babies eventually have the aplastic anemias and may can develop the leukemias or myelodysplasias. When you see the blood picture, the platelets are low. They can have a normal size platelets. The receptors are abnormal, so there will be high amount of the thrombopoietin receptors. When you go with the bone marrow, we don't have any megakaryocytes because the receptor is not there, so the megakaryocytes differentiation not happening. In the case of type 1, there is only choice with hematopoietic stem cell transplantation. Then you have viscotology syndrome, where the patients usually see the male babies for extreme risk to the babies present thrombocytopenia, there is atopic rash, and then recurrent pulmonary infections. So they, because of the VASP gene on the chromosome XP1122, 1123 gene deficit lead to the viscotology syndromes. The patient uses a small platelets, thrombocytopenic purpuras. They have a small platelets, but the megakaryocytes are normal. They have a prolonged bleeding after circumcisions. They have a skin rashes, atopic dermatitis. They're more prone to the streptococcus and other bacterial infections. We have a polysaccharide capsules that will lead to more amount of cyanopulmonary infection, failure to thrive. They can also have a diarrhea, and the treatment in this is hematopoietic stem cell transplantation. So there are then symptoms like not large platelet disorders like the May-Hagelin MYH9 related disorders where they have mild to moderate thrombocytopenia, large platelets, and they can associate it with other nephritis and cataracts, all those things. So these are all the genetic disorders where the genetic analysis can lead to the better identification. Next, we move on to the late onset thrombocytopenia. The late onset thrombocytopenia is one of the most common sepsis. We need to rule out sepsis and necrotizing enterocolitis, then only we can further evaluate for any late onset thrombocytopenia. The other onset thrombocytopenia, like congenital viral or bacterial fungal infections or autoimmune disorders, can present as a prolonged thrombocytopenia. We might have identified the thrombocytopenia after 72 hours, but might have developed before also. Then there's a consumptive coagulopathy like Kazbek-Mirret syndromes. There can metabolic disorders like propionic acidemias, and there can be inherited disorders where we can identify this thrombocytopenia early and also can be late. So usually these babies appear ill with signs of sepsis or NEC. The thrombocytopenia can be the first presenting signs of this process and can precede the clinical deterioration. After, if you rule out the bacterial and the fungal infections, then we need to also rule out the HSV, CMV, enterovirus should be ruled out. We can get an abnormal liver enzymes when there is associated with HSV, CMV, and enteroviral infections. Any babies who have central venous catheter like a PICC line or central lines or US UVCs, there can be thrombosis related to the central venous catheter that can not be removed. So there can be certain drugs like meropenem and all the drugs when given high doses can also lead to thrombocytopenia. And the less common IEMs and vancomycin can present with thrombocytopenia both in the early onset and late onset. So the late onset, the first and foremost thing is we rule out the bacterial fungal infection NEC. If there any evidence of sepsis or NEC, that after giving the treatment, the platelets are becoming normal, then no need for further evaluation. So there is no evidence of bacterial fungal sepsis. We are treated with antibiotics. The NEC is not there. Still the thrombocytopenia persists. Then we need to rule for the DAC. Viral infection like HS, factoid CMV, enteroviruses, thrombocytopenia suspected central is present. If you are giving any drugs like meropenem related to thrombocytopenia, we need to change the drugs. We should consider inborn metabolism. The babies also have the metabolic acidosis and elevated amount of ammonia, hypoglycemia. We can have the propionic acidemias, methylmalonic acidemias. If there is any structural disorders, we can also lead for the along with anemia. We can have the vancomycin in these conditions. So how do you manage the neonatal thrombocytopenia? One, we identify the disorders like sepsis and NEC and we treat the disorders. In the case of and second, you do supportive management. We need to give the blood products. We need to get the blood pressure monitor maintenance, and when to correct the DACs. The one of the important thing is we need to use the platelet transfusions. So this is in every table where you can see that they suggest that less than 25, you can transfuse all. If 25 to 49, if there is any major hemorrhage in the last 72 hours, like grade 3 or grade 4 IVH or any prior to surgical procedures, we need to transfuse maintain beyond 50,000. We can maintain a higher threshold. We can maintain high platelet count if there is an active bleeding or we have a NATE with intracranial where we want to maintain beyond 1 lakh, or we want to do any neurosurgical procedures also, we want to maintain a much higher level of the platelet. This is the latest CLO-RT where they consider that less than 30,000 they want to transfuse. 30 to 50,000, they'll transfuse the birth weight with VLBWs and any in the early neonatal period. The baby is clinically unstable or anyway NEC, coagulopathy, major hemorrhages, and prior to surgical procedures. They suggest to transfuse between 15 to 12,000 if there is an active bleed and 8 within intracranial bed or before any neurosurgical procedures. So even NF suggests that less than 25,000 should be the cutoff where the baby doesn't have any bleeds and doesn't have any history of intracranial hemorrhages. So there's a famous Planet 2 trial then where they found that whether to give the platelet counts of 50,000 as a cutoff at the high threshold or at 25,000 for the low threshold. The primary outcome was death or the new major bleeding in the first 28 days. They found that the major bleeding episodes or death happened in a less number in the case of a low threshold group where they're transfusing at 25,000 rather than giving it 50,000. So the conclusion is the transfusion of platelet 50,000 has led to higher significance of death and major bleeding compared to the patients who are receiving around 25,000. So in the case of a asymptomatic, without any ICH, without any NATE, without any major surgeries and bleeds, we can maintain the baby's platelet count beyond 25,000 without giving any transfusions. So the standard is we can give around 10 to 15 ml per kg standard platelets. We give the random platelet around 5 ml per kg. The platelet count rise by 30,000. We can store this platelet around 5 days. The half-life of a platelet transfuser is around 70 to 96 hours only. Similar to any other transfusion, there can be CMV transfusion, graft-versus-host disease, bacterial infection, and transfusion of lung injury can happen. We need to monitor. If you go for the RDP is derived from the whole blood by centrifugation of the blood. So when one donor, so in the case of random, we take the whole blood and with the centrifugation, the 1 unit of the platelet will rise by around 10 to 5 to 10 into 10 to the power of 10 platelets. This is not leukoreduced, so there's more chance for the aluminization, more exposed to the random platelets, more chance for the aluminization, more chance for the graft versus. As we are not doing any apheresis, it's very cheap. The single donor platelet, even though it's costly, they take for a single platelet, they do the apheresis and concentrate the platelet. They can rise the platelet by 3 into 10 to the power of lag by single units. That is leukoreduced because you're doing apheresis, so the aluminization chances rate because you're exposed to single donor, however, it's very costly. It is equivalent to the 4 to 6 RTPs. So always in a newborn, we try to give the single donor platelet in order to decrease the chance for the exposure to the multiple donors and less chance for the aluminization. So immunodeficient infants, the babies are mostly immunodeficient. So we need to give the leukodepleted blood to prevent the GVHD. So always try to get the SDBs. Platelet transfusion also has a high chance of platelet contamination. Meticulous care to be given in order to prevent bacterial transfusions. Any transfusion can lead to the trallies. We need to maintain the strict monitoring of the respiratory distress. And the chance for the transfusion and the NEC is also there. So we need to monitor for the gut-related injuries. But platelet transfusions till now any studies have not shown to increase the risk for the NEC. So there is no need to withhold the feed during the platelet transfusions. So there are certain drugs like romplastine, L-thromboplag. These are the thrombopoietin limiting agents. These are used for the adults who are having the chronic ITPs. In 2000, L-thromboplag was approved for even the children with MYH9 mutations, viscoelastic syndromes, and aplastic anemias, where it want to provide the megakaryocytic stimulation and promote thrombocytopenia. So they can rise the platelets by 4 to 6 days after initiation, peak by 10 to 14 days. However, the problem in the infants and the newborn babies is the duration of thrombocytopenia production is very difficult. So which happen the use of thrombopoietin mimetics agents in less than 1 year of age. So there are certain many other conditions called thrombocytopenia. So with this we conclude. We suggest you to read Avery's and friend of Martin Cloherty have a much more idea how do you want to manage the thrombocytopenia. So first we think what is whether it's early onset or the late onset thrombocytopenia, whether the baby is sick or non-sick. Based upon that, we can assess the thrombocytopenia. Suspect sepsis, NEC. In the case of any sick baby, whatever the size of thrombocytopenia, it's a mild, moderate thrombocytopenia, you suspect the sepsis and NEC. Once you ruled out them, the baby is clinically stable with the history of any placental insufficiency, improving over 7 days, then it could be a placental insufficiency related thrombocytopenia. Any baby severe thrombocytopenia, whether the baby is sick or not sick, after lung sepsis, always suspect NEAT if it is an early onset thrombocytopenia. If you have ruled out NIT, if you ruled out sepsis, and if you have ruled out the NEC, congenital viral infections is the one most thought process one should be think of late on the thrombocytopenia babies, premature babies who have received the multiple blood transfusions, or sometimes even from the premature breast milk also the CMV can be transmitted. So thrombocytopenia not able to set up with any other settings, rule out CMV. Herpes simplex, mother had a history. Usually we can predict the herpes simplex virus infection, but CMV is the one should be ruled out. Any baby who had a thrombocytopenia, received any transfusions or premature babies, don't find any other cause, rule out CMV. You can just send a urine CMV. We can identify urine CMV temperature. They will identify the urine CMV, which is easy to do, and the sensitivity is much higher. Don't give the platelets for all the thrombocytopenias. If the baby is not sick, no IC bleeds, you can wait till 25,000, at least maintain 30,000, below 30,000 only give the platelets, because giving the platelets with the high threshold, giving around 80, 90,000, so if you give the platelets, even around 40,000, if you give the platelets, the chance for having the mortality, chance for having the BPD, NEC are much higher for giving the platelets, because you are exposing the babies, preterm babies, to the something that is not necessary, that is high risk for having bacterial infection, high risk having CMV infection, high risk having the graft versus host disease. So always try to identify the cause, treat the cause, give the platelet judicially. And if you're not able to identify the common causes, then extensively evaluate the babies to go for any other serious conditions. So with this, I conclude my presentation. Thank you for patient listening.